Hi, and welcome back to another Greenstein Rehab production. I'm Lauren Klump, and today we are talking about treatment for tension headaches. I am happy to introduce our speaker today, Dr. Jay Greenstein. Dr. Jay is the CEO and founder of Greenstein Rehab Companies, and he leads a team of doctors across our 6 different chiropractic and physical therapy clinics here in the DC area. Dr. Jay is also very heavily involved in advocacy in the chiropractic field, and he has many roles, one of which is the chairman of the Chiropractic Council, the chairman of the Council on Chiropractic Guidelines and Practice Parameters. And that organization is responsible for setting forth many of the evidence-based treatment protocols to ensure the best possible patient outcomes. So I give you Dr. Jay.
Thank you, Lauren. Yeah, I know the Council on Chiropractic Guidelines and Practice Parameters is a mouthful. We are renaming our organization to the Clinical Compass because of just that reason. So thank you very much. And also thank you, everyone, for being here today. It's a great pleasure to discuss this really important topic of the evidence-based approach to treating tension-type headaches. So we're just going to briefly go through the agenda. First, we're going to talk about the why. Why are we having this conversation today about tension headaches? Then we're going to define exactly what a tension headache is and also get a good understanding of the difference in symptoms between a tension-type headache from, let's say, a migraine or from a TMJ headache or other types of headaches like cluster headaches. Then we're going to talk about the causes and the risk factors for tension-type headaches. And lastly, and possibly most importantly, we're going to talk about the clinical evidence around appropriate treatment and management of this very, very important condition. So again, the why. Why are we here today? Why are we talking about this? And our vision statement is inspiring and empowering a healthier, happier world. And so part of that responsibility, part of that social responsibility is to ensure that patients have as much education as possible so they can make the best decisions about their health care. And there's a lot of information out there that you can find on the internet or on YouTube, and we just want to make sure that you have the right information that's based on the current scientific evidence, which is something that's very near and dear to my heart. So let's talk about the why. Why are we talking about tension-type headaches? Well, first of all, it's the most common primary headache disorder. These types of headaches affect approximately 1.4 billion people, or 21% of the population. Now, there are 2 types of tension headaches. One is called episodic, the other is called chronic. Episodic tension-type headaches occur on fewer than 15 days per month and is reported by more than 70% of the population in some studies. Chronic tension-type headaches are occurring more than 15 days per month and affects 1 to 3% of adults worldwide. So you can see this is a very common and also a very broad problem. Tension-type headaches often begin during the teenage years, and they affect 3 women to every 2 men. So women are getting this more frequently than men. The mechanism may be stress-related or associated with musculoskeletal problems. We'll talk in greater detail about that as we move forward. Episodic tension-type headaches attacks usually last a few hours, but sometimes can persist for several days. Chronic tension-type headaches can be unremitting and is much more disabling than the episodic type. I mean, if you can imagine having a headache more than 15 days a month. I mean, I personally can't imagine living my life that way. And so again, it's a common problem, it's a disabling problem, and we're here to talk about the evidence that supports appropriate management and treatment. Chronic tension-type headaches is also the most common type of recurring head pain. So again, a big problem. So let's define a tension-type headache and compare it to other types of headaches as well. So as you can see, this graphic defines 6 different types of headaches. So TMJ, head type pain or headaches, is pain at the temples and in front of the ears. A sinus headache is typically pain behind the brow bone and or cheekbones, and you can see, and I'm going to use my little fancy highlighter here, which is really fun for me. You can see, oh, not my highlighter, I want to use my laser pointer. I have that tool too. You can see right here where the pain pattern is. Okay, and again, in TMJ headaches, usually the pain is located right in front of the ear and around the temporal region. Cluster headaches literally are headaches that occur right behind the eye, and they're very severe and very focused and typically unilateral, so only on one side. The tension type headaches are described like a tight band that squeezes the head. So from temporal region across the frontal region and then around to the, excuse me, the other side of the temporal region. Also, patients many times will describe pain and or tightness behind the ear and in the neck that can also refer pain into the head. Migraine type headaches, you can see, are much broader. They're unilateral typically, but they're much broader than a cluster headache, so a much bigger pain pattern. And a cervicogenic headache or a neck headache, also, pain stemming from the cervical spine, and can also be found to have referred pain into the top or back of the head. So I'm going to turn off my laser pointer and move forward. So again, we can sometimes see that there's tightness on top of the scalp or pain upon brushing your hair. There's also occipital tension with tension type headache. So really the base of the skull, rigidity of the neck muscles also contribute to this condition. It feels like a band-like constriction in the front of the head. You can have tightness around the temporal region, around the temporalis muscle. And when these muscles contract, the pressure can sometimes, or the pain can sometimes be accentuated. It can be accelerated. So what causes these types of headaches? Why are patients having these types of headaches? So again, we described the fact that there is tension in the muscles of the face and in the neck and shoulders that contribute to these types of headaches. The normal metabolism of glucose, our energy for our cells and our muscles. The normal metabolic byproduct is lactic acid. When lactic acid can build up in a muscle, many times that will create trigger points, areas of tenderness and tightness that will refer pain not just locally, so you might not just have pain locally, let's say, in the neck or in the base of the skull, but also can refer pain all the way around to the front of the head. Here's an example of a variety of trigger points that have been mapped by scientists and clinicians for many, many years. So we can see here that we can have local trigger points in the temporalis muscle that can refer pain just in the same exact pattern that we discussed, more in the frontal region as a band-like type of pain around the front of the head. And again, this can be in the temporalis muscle, this can be at the base of the skull, this can be in the cervical spine. These are typical pain patterns where trigger points have developed and create pain into these regions. And this will create head pain and specifically tension type headaches. Another really important source of pain that must be not only identified but addressed and resolved, and we'll see how it gets resolved when we talk about treatment, is pain that comes from the joints in the neck. Now we have 7 bones in our neck. We can see here that these are the discs, which are the cushions between the bones. These are the nerves that exit between each of the bones. And of course this happens on both sides of the spine. And then here are the joint spaces, or the joints, the connections between the bones. Now these joints are also innervated. They're covered by a capsule. And when not moving correctly, they can cause local pain and referred pain, just like the trigger points that come from the muscle tissue. So the important thing to understand about these issues, these contributing factors, these risk factors and causes for tension type headaches, is that they are mechanical issues. And mechanical issues require mechanical solutions. And so as we go through some of the information and some of the science around how these things have been treated in the past, and we look at what works, it's going to be very interesting to see how chemicals typically are not working for these types of headaches and mechanical solutions are working for these types of headaches. And that just makes good sense. It's just logical. We've got a mechanical problem. We need to fix it with a mechanical solution. If a muscle is tight, we need to work out the tightness. If the joint's not moving correctly, we need to move correctly. These are very, very simple concepts. They're evidence-based concepts, and the treatments are proven, and we will get to that in just a minute. What causes these mechanical issues to occur in the first place? Well, we are typically not very good to our bodies, and especially as it relates to posture. And this is just one example of an incorrect posture. We can see how the computer screen is too low, and of course that causes the head and neck to drop forward, which creates additional tension and stress on the neck and the muscles of the spine. It also creates actually problems in the lower back, because as the head goes, the rest of the body will follow. And if we think about the spine as a series of bricks and jelly donuts, when the front of the bricks come together, it literally will squeeze out or push back the jelly towards the posterior part of the spine, which is where the spinal cord and nerve roots are. So this is not just a postural issue, but it can become a much more serious issue as it relates to spinal degeneration. So this is just one of the reasons, however, that we can create mechanical issues in the muscles of the spine and the head, and of course the joints of the spine as well. Just as I'm on the slide, what we'd like to see in terms of a good situation is where the ears would be over the shoulders and the shoulders would be over the hips, so the head would come way back here, and we would have almost a 90-90 relationship between the plane of the head, shoulders, and hips, and of course the hips and knees. One way we do that is that we raise our computer screen. So if you were looking at me right now, you would see me. I know you are looking at me right now, but if you were looking at me from the outside, standing, let's say, to my right, you would see that the middle of my computer screen is literally at eye view. And therefore, I'm not having to hunch over and work on my keyboard and look down at the computer screen. So ergonomics and posture play a major role in helping to prevent these issues from occurring in the first place. And again, we just talked about the increased level of stress on your neck muscles when you have poor posture. These muscles have to work a lot harder, when the lever essentially is being stressed, because you've got the head, which is 3 inches forward because of poor posture. So again, you want your ears over your shoulders to ensure that you minimize stress to the muscles and joints of the spine, which then minimizes your risk for having these types of headaches. In clinical practice, we see this literally every day. This is our garden variety patient that comes in with tension type headaches. They typically will have what's called an upper crossed syndrome. And of course, just posturally, you can see that the head is forward as it relates to the shoulders, so the posture is poor. The shoulders are rounded, and the reason behind this is because you've got this musculoskeletal, I'll use the word imbalance that's occurring, and so it creates these postural issues, which then creates the mechanical strain on the muscles and joints of the neck and head, and of course leads to tension type headaches. So you've got, with upper cross syndrome, very tight upper trapezius muscles, which are the muscles right here, the muscles that help you shrug your shoulders, and the levator scap muscle, which keeps your scapula in place. This muscle runs from the shoulder blade all the way up to the base of your skull. You've got weak, deep neck flexors. This is the muscle that actually helps bring your head back into a neutral position. If this muscle is not firing, you can see how the head will come forward. A tight sternocleidomastoid muscle, we call this the SCM, and pectoralis, so the chest muscles are very tight, pulling your shoulders forward, and the muscle that we see here that goes from your ear down to the sternum and the clavicle, this muscle right here that we see, that you see like when you turn your head and neck, this muscle right here is very, very tight. And then of course weak upper back muscles, the middle trapezius, the lower trapezius, and also one of the muscles that stabilizes your scapula. So we have tight against weak. We have what's called, again, this upper cross syndrome. These postural issues are very, very common in tension type headache patients. Another big factor of tension type headaches is just stress. It is a risk factor for bringing on these types of headaches. It creates, we know that stress creates muscular hypertonicity. Our muscles want to get really tight or are getting really tight when we're under stress. And so again, this can be a strong contributing factor for tension type headaches. So managing stress is a really important component of treatment. All of these factors, posture, poor mechanics, and stress lead to a patient just feeling like their head is being crushed. So how do we fix these problems? And again, I confidently use the word fix. I've seen it in over 20 years of clinical practice, and it's also supported by the scientific evidence. So what does the evidence say about how to manage these conditions appropriately? Well, in order to understand evidence, and I apologize in advance for totally geeking out on everybody on this webinar, but I do think this is really important. There is a hierarchy on the level of science, on the level of evidence in clinical practice. And so I'm not going to get into too much detail, but a randomized controlled clinical trial is considered a high level of evidence. In fact, it's the highest level of evidence when we look at just looking at specific populations or looking at specific subjects. When we get into study level data, what this means, like a systematic review or a clinical practice guidelines, and again, I'm chairman of our profession's clinical practice guideline organization. These are the strongest levels of evidence because these two types of peer-reviewed publications, the clinical practice guidelines and the systematic reviews, they take into account groups of subject level data, groups of randomized controlled clinical trials, and look at all the evidence around the trials that have been performed or studied for a particular condition or population of patients. So it is important. You can have a case study that's very interesting, but nonetheless, it's not a high level of evidence. So what we're going to be talking about today as it relates to the proven treatment for these types of headaches is randomized controlled clinical trials and systematic reviews, two of the highest levels of evidence that are out there. You know, there are short-term treatments that have been studied and that are being utilized every single day, and there are long-term studies as well. Our goal is to focus really on the long-term impact of the treatment that works for these types of conditions. Short-term, we know people are taking these pain medications. I mean, this is a rampant problem in our country. Certainly, we know the opioid crisis is a huge and growing problem in this country. Over 18,000 people a year are dying because of prescription opioids. So how we manage pain is really, really critically important. And I think what we see, certainly with tension-type headaches, is that if they're managed in the short term appropriately, when it's an episodic problem and it's managed appropriately in the short term, then the long term doesn't even happen. And my point here, specifically with this slide, is that if an individual has a headache and it happens once a year and they need to take an Advil, that's probably clinically appropriate. But when it becomes a habitual issue, it's not going to solve the problem. And certainly as it relates specifically to the mechanical issues surrounding tension-type headaches, taking these medications, chemicals will not fix mechanical problems. That's just basic understanding of human anatomy and pathophysiology. We also understand that, again, these medications, they cause complications. And certainly with your nonsteroidal anti-inflammatory drugs and your aspirins, you know, you're talking about gastric bleeds. When we're talking about opioids, we're talking about addiction, and this is a well-known problem. And again, you know, it's a crisis in this country right now. So finding more appropriate solutions to these problems is really where the country needs to go in terms of managing population health, and it's part of my responsibility to ensure that we're educating the population to ensure that's the direction we move in. This was really an interesting study that came from the National Guidelines Clearinghouse, which is literally the storage facility, the central repository for all clinical practice guidelines. Remember, clinical practice guidelines with the highest level of evidence when looking at, you know, what actually is effective in terms of treatment. And what was shown on the National Guidelines Clearinghouse, and again, I have the reference for you in this particular slide, is the use of drugs for acute treatment of headache for more than 9 days per month is associated with an increased risk of chronic daily headache. And we call this rebound headaches. So patients have a headache, they take medication, and as they do this repeatedly over and over and over again, it actually becomes a cause and a risk factor as opposed to a treatment. So what are the medications that actually cause rebound headaches? And here's a list for you right here. Aspirin, sinus relief medications, acetaminophen, which is Tylenol, is an example of a name brand, acetaminophen, nonsteroidal anti-inflammatory drugs such as ibuprofen and naproxen, sedatives for sleep, codeine and prescription narcotics, over-the-counter combination headache remedies that have caffeine in it, like Anacin or Excedrin, ergotamine medications that are listed there. I won't go through the entire list for the sake of time, and other combination pain relievers like Furacet, Furanol. All of these medications cause rebound headaches according to the scientific literature. So again, have a headache once you have Advil, great, probably not a huge problem. When they become repeated, when you have repeated headaches, it's not going to solve the problem, and again, will be a risk factor for having additional headaches. This just was published in the British Medical Journal. This looked at updates that were being made in terms of the effectiveness of medications for chronic tension-type headaches. And I think it is important to go down this list. What they're talking about in this update is they're listing the drug and determining whether or not that drug is beneficial whether or not it's unknown effectiveness or whether or not or ineffective or harmful. So let's just go through the list really quickly. Amitriptyline, beneficial for chronic tension type headaches, according to the evidence. Anticonvulsant drugs, unknown effectiveness. Benzodiazepines, likely to be ineffective or harmful. Botox, likely to be ineffective or harmful. Non-steroidal anti-inflammatory drugs, which I can guarantee you is probably the most common drug being taken for chronic tension type headaches, likely to be ineffective or harmful. Neurogenic and specific serotonergic antidepressants, categorization unchanged, likely to be beneficial. Opioids, unknown effectiveness. Paracetamol, unknown effectiveness. Serotonin reuptake inhibitors, unknown effectiveness. Tricyclic antidepressants, unknown effectiveness. Acupuncture, unknown effectiveness for chronic tension type headaches. And cognitive behavioral therapy, unknown effectiveness. So when we look at the drugs that are being prescribed out there, out of this entire list, there were only 2 that were shown to be effective. Again, I caution that drugs in and of itself, chemicals cannot fix mechanical problems. So the goal would be to fix the problem causing the pain. Also, in terms of drugs being taken prophylactically as a possibly a preventative measure, again, the systematic review demonstrated that there is no evidence that any of these medications that were listed in this study actually had a prophylactic impact or effect on tension type headaches. So what have we learned here? We've learned here that out of 11 industrialized nations, the United States is last, yet our costs per capita are the highest out of all 11 industrialized nations. We've been using medications to manage patients. Specifically, we're talking about tension type headaches today. The effectiveness is either unknown or most are ineffective. So what do we need to do in order to solve this problem for these populations of patients? So a recent study that looked at acupuncture in the treatment or prevention of migraine, tension type headaches, or chronic headache disorders found that from a purely comparative effectiveness perspective, the evidence from clinical trials and meta-analysis makes a compelling case in support of a potentially important role for acupuncture as part of a treatment plan for patients with migraine, tension type headache, and several different types of chronic headache disorders. So there may be a role for acupuncture, and if you think about how acupuncture is utilized, and you've got acupuncture points that are being addressed by needles, we're also putting these needles into the muscles, which many times are causing the pain to begin with. That makes good sense. This next study was a randomized controlled clinical trial in the European Journal of Physical Rehabilitation Medicine, again, just published several months ago. They looked at patients who had adjustments, manipulation and massage, or massage only, and what they found is that the addition of manipulation to the spine was more effective for increasing range of motion of the upper cervical spine and reducing the impact of the headache than massage alone. Again, that makes sense. So if the muscles are pulling against joints of the spine that are not moving very well, if those joints are stuck, then moving those joints through manipulation and addressing the soft tissues, the trigger points through massage, makes good sense. Again, in 2014, the effect of manual therapy techniques on headache disability in patients with tension type headaches, another randomized control trial, again reported that when 2 treatments were combined, the use of soft tissue work as well as manipulation of the upper cervical spine, the symptoms of these headaches were dramatically reduced, including photophobia, which is the issue of light creating a problem, phonophobia, which is sound creating a problem, increasing the headache conditions, as well as pericranial tenderness. Again, in the Journal of Chiropractic Medicine in 2014, the efficacy of manual and manipulative therapy in the perception of pain and cervical motion in patients with tension type headaches, another randomized controlled clinical trial. Pain intensity improved after the treatment, and it followed with manipulation therapy and combined treatment. So here, manipulation alone and manipulation combined with manual therapy of the soft tissue were shown to be effective. Again, another study published in the European Journal of Physical Rehabilitation Medicine. Do manual therapy techniques have a positive effect on quality of life in people with tension type headaches? Again, another randomized controlled clinical trial. When looking at the treatments and the treatment groups, spinal manipulation, suboccipital massage work, or the combination of the 2, they found that all 3 treatments were effective in changing the different dimensions of quality of life but the combined treatment showed the most change. So we're seeing a pattern here. What does the evidence say about the best way to treat these symptoms mechanically, to treat them functionally? And it's really all about combined treatment. There is an organization called the Bone and Joint Decade Task Force. It is an interdisciplinary task force made up of MDs, PhDs, physical therapists, chiropractors, scientists in public health, and they've been studying neck pain, and they've been studying headache for many years, well over a decade now, and here's what they found. They published this in European Spine Journal in July of 2016. The evidence suggests that episodic tension-type headaches should be managed with low-load endurance, cervicocranial, and cervicoscapular exercises. So exercises that manage stability of the neck and head, as well as stability of the neck and shoulders. Patients with chronic tension-type headaches may also benefit from low-load endurance craniocervical and cervicoscapular exercises, so also improving the endurance of how the neck muscles fire and maintain their capabilities through your activities of daily living. Relaxation training, of course, makes sense to manage stress, and of course multimodal care that includes spinal mobilization, cervicocranial exercises, and postural correction. So we talked at the beginning about these causes of tension-type headaches. You've got poor posture, you've got the upper cross syndrome, which is a mechanical issue related to the function of the muscles and the joints of the spine, and of course you've got stress. So what would make sense? You manage all three elements in the treatment of these conditions, of this condition. Medication won't treat function, it won't treat posture, and it will not treat stress appropriately, except for the antidepressants that were shown to be helpful. So I just want to, again, make that point clear. For cervicogenic headaches, low-load endurance cervicocranial and cervicoscapular exercises or manual therapy, manipulation with or without mobilization to the cervical and thoracic spine may also be helpful. So essentially what that means is manipulation not only to the neck but also to the mid-back has been shown to be beneficial. And again, this is a systematic review. This is looking at all the evidence that has been out there. They looked at over 17,000 citations. They found 15 studies that were relevant and 10 that had a low risk of bias. So they accumulated the best evidence, and the conclusions were very, very clear. So to manage the trigger points in the head and neck and shoulders, massage therapy is an appropriate technique. Soft tissue therapy is an appropriate technique. And again, there are many different forms of massage therapy. You can use trigger point therapy, instrument-assisted soft tissue techniques like Greenstein. There are many, many ways that we can skin that cat in order to reduce tension and remove trigger points in the cervical spine and head. Spinal manipulation, again, shown to be effective in the treatment of tension-type headaches to improve joint function, and specific exercises to address the postural concerns that we deal with when managing patients with these types of conditions. And of course, lastly, acupuncture, as we discussed, helping to manage the pain for these types of headaches as well. The great news about these treatments is that they are 100% natural, and most importantly, they're safe. So for patients out there suffering from tension-type headaches, the most important thing is find yourself a healthcare provider that provides a variety of treatment techniques and tools to use to enhance the patient experience and get the best outcomes that aligns with the scientific literature. So I want to thank you very much for joining me today. My email address is enclosed here in this slide. I'm always happy to take any questions or comments that you have about this webinar. Again, our goal is to inspire and empower a healthier, happier world, and anything I can do to that end, please feel free to reach out to me. So I want to thank you for joining me today, and I'm happy to answer the questions that we have.
Thanks, Dr. J. We had a couple questions come in. So this first one is from someone who has been taking pain medication for quite a long time for frequent headaches, and they're wondering, if they were to come in and see a doctor at our practice, how quickly would they be able to get, diagnosed that it's a medical issue, and how quickly would they be able to start experiencing some relief?
Yeah, that's a great question. So in terms of being able to diagnose the problem, it's actually a really simple condition to diagnose. The clinical criteria is very, very straightforward, and we have tools and evaluation techniques, orthopedic testing, neurologic testing that we do in order to identify what the pain producers are that's creating the pain, as well as, and this is very important, the functional issues behind those pain generators. So that happens, at the first visit. Either they have this type of headache or they don't. And then once we understand what the condition is, either we can help that patient and we go through, what the evidence says, just very similar to what we did today, although in a more compact way about how we would treat this particular condition. We also talk about treatment frequency and duration. There's really good evidence out there actually as it relates to dosing. And what we've learned in the scientific community is that we understand that if a patient is going to be a responder to this type of care, to conservative management, they're going to respond in the first 2 weeks. So usually that's somewhere between 4 and 6 visits. And if they're responding and there's 10 to 25% improvement in symptomatology, then we will continue the course of care. And if they're not responding, then we need to either change up the care that we're delivering and or refer the patient out for further evaluation or an opinion from a different type of healthcare provider. And our network of healthcare providers, medical physicians and naturopaths and acupuncturists is very broad. We have a really extensive community network of physicians and healthcare providers that we work with. So if we're not the place for you, we're able to locate a healthcare provider that potentially could help with that particular problem. But if it is truly cervicogenic, tension type headache in nature, there's no question about it. We should be able to see results within the first 2 weeks.
Great. So another question here. So they've never had a chiropractic adjustment. So what should they expect?
Yeah, that's a really great question. Just like soft tissue techniques, there are many different types of chiropractic adjustments. In school, we spend a lot of time learning a variety of techniques, and so what I will call the garden variety chiropractic adjustment is what we call a diversified technique. And what happens is the joint is palpated, we identify the area of restriction, and we provide a quick but gentle manipulation to that joint to get it to move through its normal range of motion in the spine. What you hear from that adjustment, when we gap the joint, we're literally, and that's what the manipulation does, the adjustment does, it actually gaps the joint to create better movement, easier movement between the joint surfaces. When we increase the space between those joints, and it's very, very small, but we do increase the space because it's very compact, we increase that space a little bit, that increases the volume of the joint space. Now there is fluid in there, synovial fluid in there, and within that synovial fluid, there are gases that are dissolved, much like a bottle of champagne that has the gas dissolved. When you open up the bottle of champagne, it goes pop because you've now increased the volume of that space. It's the same thing with an adjustment. We increase the space of the joint, we increase the volume, that decreases the pressure, and the gas, the carbon dioxide gas that's dissolved in the synovial fluid, actually escapes. And that's the popping sound that patients hear. Sometimes it freaks people out. Sometimes people love it. Every individual has kind of a different response to it. But the one thing to know is that it's safe, very, very safe, and that's not an opinion. That's an evidence-based fact. And it should be gentle, and it should be fast. So if you've got a skilled healthcare provider that's providing this to you, then they're going to be fast and they're going to be gentle and they're going to be able to move the joint to get it to move through its normal range of motion or to the best of its ability. If you've got chronic degenerative arthritis or things of that nature, maybe the motion wouldn't be as good as if you have a healthy spine, but nonetheless, we're going to get that joint to move through its best range of motion, and then of course address the soft tissues through massage and also exercise to ensure that we can maintain that motion and function in that joint over time. And that's a key point, one of the things that's really missed very often. A patient will go to the chiropractor, they'll get an adjustment and they'll get some temporary relief. And then they'll go to the physical therapist and they'll get appropriate stabilization exercises, but they're not getting them together. And so they're frustrated because I feel better, but I know I need these exercises, but yet nothing's really working. It's the combination of these treatments that actually drives the best outcomes for patients. And what's really great, for us is we've been doing that for over 20 years, and the evidence supports it. So I hope that answered that question.
Thank you. And then we just have one last question. This is from someone who says, I had no idea that the medication I was taking could actually be causing me more headache. Should I talk to my primary doctor about this?
Absolutely. Absolutely. And if you need the list of medications from the presentation, I am more than happy to send it to you, email me, and print it out and sit down with your physician and say, you know, I'm not getting any better. I've been taking these medications. This may be contributing to my problem according to the evidence, and you know, what do you suggest? And quite frankly, if you truly have a tension type headache and they're not suggesting the evidence-based treatments that we've discussed today, that's a cause of great concern for me, and should be a cause of great concern for you as well.
Great. Well, fantastic. Thank you so much, Dr. J. Thank you, everybody, for joining us for another production and for your great questions.
Thank you.
We will see you all next time.
Yes. Bye now.